Hello. In case we haven't met yet, my name is Adam Reynolds. I'm one of the consultant neonatologists in Belfast. I want to talk to you about the Neuroprotection Care Bundle. It's a quality improvement initiative that we are running in the neonatal unit. The aim of the initiative is to reduce the rate of severe intraventricular hemorrhage to less than 5%, but we need everyone's help to successfully implement the bundle. So thank you in advance for watching this video. The Neuroprotection Care Bundle is an interdisciplinary effort involving members of the nursing leadership team, as well as Catherine and Gail from the allied health professional team. I also want to point out that there are numerous people from the medical side involved, including myself, Katerina Stefkova, Naomi Bell, and Emma O'Brien is one of the advanced neonatal nurse practitioners who's a member of the team registered with Safety Quality Belfast. So if you have any questions or suggestions for the team, there should always be somebody around who can talk to you about that. We may also be looking for somebody to help with some data collection, and ultimately the results of the project will be disseminated in a formal context. So if you make a contribution, it will be recognized. Whenever we are deciding on a care plan with parents, it's very important to take their individual priorities into account. But as a group, parents value developmental outcome very highly, and severe intraventricular hemorrhage is definitely an important part of what determines the developmental outcome. But I want to highlight that it's only part of what determines that, and I'll talk a little bit more about that in a while. But for now, suffice to say that not only are there additional types of preterm brain injury, including periventricular leukomalacia in subtle and more obvious forms, but also the developmental outcome will be determined by dysmaturation. Dysmaturation is something we're recognizing more and more because we know that babies who are born prematurely, even though they often have normal MRI brain scans, are at increased risk of adverse outcomes. And the term neuroprotection is applied to a variety of interventions, some of which start before the baby is born and they proceed all the way up to at least the point of discharge. However, in this context, when we're talking about neuroprotection, we're talking about specific efforts to reduce intraventricular hemorrhage. And intraventricular hemorrhage is important. Particularly the severe grades 3 and grades 4, but we recognize that grade 1 and grade 2 IVH also are associated with adverse developmental outcomes. Some of that observed effect may be due to confounding factors, but we also believe that grade 1 and grade 2 IVH can have a direct impact on the germinal matrix. The germinal matrix is located in the lateral ventricles, and it contains the precursor neurons and glial cells that migrate out from there to form the structures of the brain. Obviously, bleeding within the germinal matrix can affect that process. So while the goal of the project is to reduce the rate of severe IVH, preventing any IVH is probably beneficial. This slide shows the increasing risk of death and adverse developmental impairment with increasing grades of intraventricular hemorrhage. I would like to point out, though, that even babies with the most severe forms of IVH may have no severe impairment in the long run. And that's because all grade 4s are not equal. The impact of a grade 4 intraventricular hemorrhage will depend on, for instance, whether it is unilateral or bilateral, the size and location of the intraventricular hemorrhage as well. The impact of a bleed is not only determined by factors associated with the bleed, but also by factors related to that baby and their environment. And the study that this figure is taken from shows that quite elegantly. In this study, babies were divided into 3 groups according to the level of maternal education. The orange group is babies whose mothers had a postgraduate degree, the blue group is babies whose mothers had an undergraduate degree, and the black group is babies whose mothers had neither an undergraduate or a postgraduate degree. And you can see there are 2 lines for each group. The solid line is the IQ that would be predicted in the absence of any brain injury, and the dashed line is the observed IQ in babies who had brain injury. And what you can see is for the babies with the highest level of maternal education, there is very little difference between the predicted IQ and the observed IQ. Whereas for babies whose mothers had no third level degree, there is quite a gap. And the hypothesis that is generated by this observation is that there is a degree to which the impact of a brain injury can be compensated for by additional factors, be they genetic or be they environmental. Another way to look at this is that the impact of a brain injury is greatest on the population that is the most deprived. So hopefully we now all agree that intraventricular hemorrhage is a problem that we need to tackle. But to do that, we need to understand when it happens, who it happens to, and why it happens to them. So let's begin by talking about when it occurs. It won't be a surprise to many of you to hear that most IVH happens within the first 72 hours of life. But if we dig down into that a little bit more, we can see that there are 2 peaks in the onset of intraventricular hemorrhage. One is in the first 6 hours after delivery, and one is between 24 and 72 hours after delivery. And the point that I want to emphasize with this data is that when we are applying the neuroprotection bundle, it's very important that we do it from the moment the baby is born. Those first 6 hours of life are particularly important. Intraventricular hemorrhage is closely related to the degree of prematurity, and that's particularly true for the most severe grades, grades 3 and grades 4. We apply the neuroprotection care bundle to all babies born before 30 weeks of gestation. And it's very important that we apply the bundle as stringently to babies born at 28 and 29 weeks as we do to babies born at 23 and 24 weeks. And the reason for that is because 1/3 of the severe IVH that we saw in 2023 happened to babies born in that later group. One of the reasons that intraventricular hemorrhage is so closely related to prematurity is because there is increasing activity of the germinal matrix in more and more preterm babies. The germinal matrix starts to involute from around 26 weeks, and it slowly gets smaller and smaller in size until by 34 or 35 weeks, it's really just a remnant. At that stage, the role of the choroid plexus is really just to produce cerebrospinal fluid rather than to support migrating precursor cells. The germinal matrix contains very fragile capillaries, and that is why the germinal matrix is so predisposed towards bleeding. Essentially, these blood vessels are not designed for extrauterine life, and that's shown in some of the images here. You can see in the right-hand column the blood vessels from the white matter contain a lot of fibronectin, and the astrocytes are closely wrapped around the capillaries, whereas in the germinal matrix, the blood vessels are deficient in fibronectin, and the astrocytes are not really related to the blood vessels at all. So fragility of the germinal matrix capillaries is a large part of what contributes to the pathogenesis of intraventricular hemorrhage, but it's not the only factor. In terms of things we can alter, there are 2 main groups to consider. The first is fluctuations in cerebral blood flow. The preterm baby has a greatly reduced capacity to auto-regulate cerebral blood flow. That means that compared to an adult or an older child, fluctuations in the systemic circulation will have a much closer, almost linear effect on cerebral circulation. So not only is it important that we avoid systemic hypoperfusion, but also that when we are correcting abnormalities of systemic perfusion, we do so in a gentle manner so as not to rupture those fragile germinal matrix capillaries. There is, of course, some capacity for cerebral autoregulation within the preterm circulation, and that is why it's important for us to avoid very high CO2 levels greater than 8.0 kilopascals, and also very low CO2 levels, less than 4.5. The next factor that I wish to talk about is impaired cerebral venous drainage. As I'll talk about in a few slides, impaired venous drainage has a great effect on the most severe grades of intraventricular hemorrhage. And so it's important that we do everything that we can to optimize the venous drainage. To do that, we need to avoid things that will elevate intrathoracic pressure, such as pneumothoraces or high ventilator pressures. And we need to help keep the baby's head in the midline and the head elevated. You may note that I have not mentioned coagulopathy as part of the pathogenesis of intraventricular hemorrhage. Certainly, greatly deranged coagulation factors may predispose towards intraventricular hemorrhage, but studies where samples were taken before bleeds have shown that, at least as measured by PT, APTT, and fibrinogen levels, coagulopathy does not seem to contribute to most cases of IVH. Sometimes a baby will have been very unstable around the time of delivery or antenatally, and we will be very relieved to see a head scan result at 24 hours of life that shows no significant bleed, only to be disappointed later when on day 3 we see a grade 4 IVH. And the reason for that is that, as the earlier slide about the timing of IVH showed, there are 2 peaks in the onset of intraventricular hemorrhage, one early and one late. And the later type is probably because of the mechanism shown in this diagram, whereby there is an initial ischemic episode which damages the capillaries, and it is only later on during the reperfusion phase that those blood vessels burst. The grading of intraventricular hemorrhage is really beyond the scope of this talk, and there will be more education about that at a different time. I just want to point out a few things here. The first is that accurate diagnosis of intraventricular hemorrhage is very important so that we can accurately assess the impact of our interventions. So it's important that all images are of high quality and reviewed by a consultant neonatologist, and where there is any doubt or a severe IVH, that a radiologist performed cranial ultrasound is requested. The last thing that I want to point out on this slide is that, according to the revised Joe Volpe grading scheme for intraventricular hemorrhage, we recognize that grade 4 IVH is a bit of a misnomer. Grade 4 IVH is in fact periventricular hemorrhagic infarction. A grade 4 intraventricular hemorrhage is not a grade 3 intraventricular hemorrhage which has burst through the walls of the lateral ventricle. Rather, what happens is that bleeding within the germinal matrix or within the lateral ventricles causes pressure on the veins which drain the periventricular white matter and run adjacent to the lateral wall of the lateral ventricles. And that pressure causes distension initially, and ultimately, if it's severe enough, venous infarction. The relevance of this to the neuroprotection care bundle is that it gives a rationale for our focus on optimizing venous drainage, i.e. midline head positioning, elevation of the head of the bed, and minimizing the intrathoracic pressure. The next thing we need to know before embarking on a quality improvement initiative is how we are doing at the moment. This slide shows data from the Vermont-Oxford network, which is a benchmarking network so that data from different neonatal networks and units can be compared. This slide compares the rate of intraventricular hemorrhage for Northern Ireland to other networks who contribute to VON. You can see in the left-hand side of the figure that the rate of any intraventricular hemorrhage for Northern Ireland is above the 75th centile for neonatal networks. The rate of severe intraventricular hemorrhage is obscured by the video, but suffice it to say that the rate of severe intraventricular hemorrhage for Northern Ireland is within the interquartile range, but on the upper limit of it. The median for the network in 2022 was approximately 5%, whereas our rate was approximately 8%. And that rate has remained more or less static over the last couple of decades. You can see that between 2004 and around 2013, the rate was around the middle of the pack, between 5 and 10%, but since approximately 2014, the rate has bounced around the 75th centile for neonatal networks. And the fact that intraventricular hemorrhage has not declined in line with the reduction in mortality that we have seen over recent decades is not unique to Northern Ireland, but is a problem that is facing neonatology globally. Before I start talking about the individual aspects of the bundle, I want to talk about some things which aren't part of the bundle but are still really important to prevent intraventricular hemorrhage. Preventing intraventricular hemorrhage starts before a baby is even born. I can't overemphasize how important it is to transfer babies antenatally to Belfast. A baby who is born in a district general hospital below 27 weeks is at a roughly a 50% increased chance of developing an intraventricular hemorrhage. The other intervention to mention, which is antenatal, is steroids. Most people think of antenatal steroids as reducing RDS, and it's true, of course, that they do reduce RDS, but perhaps by lowering the risk of pneumothorax, by allowing us to use lower ventilator settings and improving cardiovascular stability, they do decrease the risk of IVH. Delayed cord clamping is another intervention which we are already implementing, but it's very important to the efforts to reduce IVH. We believe that that is because the increased volume, perhaps even the higher hemoglobin, it helps to stabilize the cerebral circulation and therefore reduce instability during that critical early period. Avoiding intubation wherever possible is a well-established principle in neonatology, and there's nothing in the neuroprotection bundle that goes against that, as long as you can maintain steady perfusion without intubating the baby and normal CO2 levels. Intubation itself has a great impact on cerebral circulation. Obviously, there's a change in the baby's neck position, and oftentimes desaturations and bradycardia. So for a baby who's very vulnerable, I would say that that's not the time for somebody who has limited experience with intubation to be intubating for the first time, for instance, and those high-risk intubations should be left to the most experienced person available. It's been shown that the number of intubations above 3 is linearly correlated with the risk of IVH. Do neuroprotection care bundles actually work? Well, I wouldn't be talking to you about it if I didn't believe that they could. The preponderance of the evidence suggests that they do reduce the rate of IVH. In a unpublished systematic review conducted by members of the Vermont-Oxford Network, they saw an average decline from 12% to around 8% following introduction of neuroprotection care bundles. But some reports have seen no decline in the rate of IVH, and my own explanation for that is that the results probably depend on the quality of the implementation. What is in a IVH prevention quality improvement initiative varies a little bit from implementation to implementation. Here, we got together some of the medical staff and members of the nursing team to decide what we felt would be feasible and beneficial to implement in Belfast. And here is the list of items that we decided on, but I'm going to talk about each heading individually. Aside from nursing staffing issues, the first item on the bundle is head positioning. And as we talked about already, head positioning is important because it helps to enable a stable cerebral perfusion and cerebral venous drainage. And really, it's pretty simple. It's just about keeping the head in line with the trunk from as soon as the baby is born. And we know that that can be difficult to do, particularly if a baby is intubated and there's heavy ventilator tubing attached to the baby. So what you can use to facilitate that are the gel pads, which you can see in the bottom left-hand side of the slide. These pads are reusable, so don't throw them away, but they are kept in the Neuroprotection bundle box, which is in the cupboards on the left-hand side as you walk into the NICU. They're in the far cupboard in the bottom drawer. And I would suggest that if you know that a baby is going to be born and we will be applying the neuroprotection bundle to them, just get one of the pads out and put it in the incubator that's being prepared. That way it can be put underneath the head as soon as the baby arrives, because I know when umbilical lines are being put in, it can be very hard to maintain that midline head position. The other things that we do to maintain that position are we mandate that when a baby is being turned, that two people turn the baby. That helps keep the head in line with the trunk at all times. We don't want to see any flipping of the baby of 180 degrees. So we also mandate that a turn position is at most 90 degrees at a time. Another aspect of positioning that's all about maintaining steady cerebral blood flow is to do with the bed. So the head of the bed should be elevated to a maximum of 30 degrees, 15 to 30 degrees is what we say. And also, whenever you are examining the baby's rectum or spine or even changing a diaper, it's important not to, yank the baby's feet up, because that can result in a bolus of blood from the lower limbs returning to the right side of the heart and resulting in a rapid fluctuation in cerebral blood flow. So if you do need to examine the baby's rectum, do so without lifting the legs. You can rotate the baby slightly to the side. But this slide is about fluid administration. It can be hard during a busy on-call shift when you have multiple gases to do, to aspirate from an arterial line slowly, but I think it's really important that we take the time to do that. And if you're really rushed off your feet, maybe there's a nurse who would kindly take the time to aspirate slowly from a line on your behalf. Studies of near-infrared spectroscopy show that very rapid aspiration from an arterial line does result in a decrease in the delivery of oxygenated hemoglobin to the brain. So based on a few admittedly small studies, a consensus has been reached that you should not aspirate or flush from an arterial line at a rate above 1 mil over 30 seconds. And you can use an incubator timer to slow yourself down, or you can simply count to 30 seconds in your head. That should be accurate enough. Similarly, when we're flushing from lines, we don't want to be inadvertently giving the baby large volumes of fluid, often very rapidly if they are given. So Naomi Bell has produced this table which shows you the volume of all of the lines that we use inside the NICU, and it's probably smaller than you would expect. For instance, a double lumen UVC has a volume of just 0.3 mils per lumen. Now you have to take account for the extensions that may be attached to that, but really it should never be required to flush a line with more than 1 mil. The next thing to mention here is the speed of infusion of saline boluses. So rapid administration of a lot of fluid is going to result in potentially a rapid increase in the cardiac output, and that's the outcome we're looking for, except it may predispose those fragile blood vessels in the germinal matrix to rupturing. So unless it's a real emergency situation, for instance where a child is bradycardic, you should be looking to administer a fluid bolus over 30 minutes. There's a saying in neonatology that all care is brain care, and partly that's because every system has an impact on the brain. And that's definitely true of respiration. Most things that we do in respiratory management can have an impact on the brain, but the aspects that are specifically paid attention to as part of the bundle are suctioning. I think previously there was mandated routine, maybe 4-hourly suctioning of preterm babies, but most babies, at least early in their postnatal life, will have minimal secretions. So we're really saying that babies only need to be suctioned as necessary. That disconnection from the ventilator can result in fluctuations in cerebral venous drainage, for instance. We are more and more using inline suction catheters here again, and there's no reason that these should not be routinely used in the most preterm babies in the first few days of life when they don't have thick, copious secretions. I've already talked about CO2 levels and their impact on cerebral perfusion quite a bit. I think the upper limit that's mentioned here is 8.5 kilopascals. I think I mentioned 8.0 earlier on. You read different thresholds in different places. I think the exact figure isn't important. The important thing is that while permissive hypercapnia is not in conflict with neuroprotection, and in fact is probably working with it because we need to avoid intubation, very high CO2 levels will increase cerebral perfusion by causing vasodilation, and that vasodilation can predispose towards bleeding. Minimizing stimulation during the first few days of life is another important part of the neuroprotection care bundle. Later on in their course, it's very important that babies have an appropriate degree of stimulation, and that's an important part of neuroprotection more broadly. But as I said, in the first few days of life, it's really about keeping the baby calm and relaxed. So to do that, we need to be using our incubator covers to reduce light exposure. We need to be reducing noise in the unit. Katerina told me that the suggested maximum noise level in the unit is 45 decibels, which is apparently around the noise level of a loud conversation. So keep that in mind during busy ward rounds and hectic times in the unit. Cares and medical examinations should be clustered whenever possible. Not every baby needs to be examined at 8 o'clock on the dot every morning. Before you go to disturb a baby who may be sleeping, it's a good idea to have a word with the bedside nurse and see if you can work out a way that you can bundle your interventions together. For instance, if a nurse is planning to do her cares at 11 a.m., maybe bloods could be safely postponed until that time. Maintaining a normal temperature, i.e. a temperature between 36.5 and 37.5 degrees Celsius, is so important. A cold baby is likely not to transition well. Their pulmonary vasculature won't dilate, and that will lead to poor oxygenation and poor perfusion as well, potentially. On the other hand, a baby who is too warm will have a high metabolic rate, and they're going to have peripheral vasodilation, leading to a lot of fluid fluctuations. There is already a quality improvement project which is ongoing, aiming to improve admission temperature, and another group are working on procedural hypothermia. It's important that we continue to use polyethylene bags to keep babies warm post-delivery. And I would like to advocate for using the servo mode on the incubators. So when you're using servo mode, a skin temperature probe is attached to the incubator, and the tip of the probe is placed over the baby's liver with an adhesive sticker. And the incubator temperature will be automatically adjusted based on that reading. Now, the probes are very likely to fall off regularly, so it's important if you see a low reading that you check that the probe is still attached to the baby, and confirm any abnormal temperature readings with an auxiliary temperature measurement. But I've tried to emphasize the importance of applying these measures during that very early period, and I think that using servo mode can be great when we are doing procedures early on, for instance, when we're inserting umbilical, venous and arterial lines. Keeping the humidity up in the incubator is also so important, so be very careful to limit the amount of times that you have to go into the incubator. Try to use the portholes as much as possible rather than taking down the sides. And if you do need to open the side of the incubator without lifting the lid, you can turn the heat boost on before you go in, and that should limit the temperature drop. Pain and sedation issues are another area where neuroprotection to prevent IVH overlaps with neuroprotection more generally. We know that the number of pricks that a baby has during their neonatal course is associated with altered pain sensation in later life. So if that wasn't reason enough to pay close attention to pain management, well, we also know that pain is going to result in fluctuations in systemic blood pressure and potentially predisposed towards intraventricular hemorrhage. So if you're doing a potentially painful procedure, well, the pain management will have to be individualized for that baby and that procedure, but I would just advocate for having another person with you, for instance, the bedside nurse, if they are available, to practice containment holding of the baby. We obviously don't use routine opioids for intubated babies, but nurses will be doing regular NPAS scores, so always make a point of asking the bedside nurse how they feel the baby's pain and agitation levels are controlled. So that's most of the elements of the bundle. I just want to mention one more, which is that we are advocating that babies are weighed using the scales built into the incubator rather than separate scales. This is to limit the amount of movement that the baby has to experience. But having talked about all of the elements, I want to talk to you about how we are implementing them, or ensuring that they are implemented as much as we can. The first thing that you see there is the cot cards. You have probably noted them around the unit already. They're located in that drawer that I mentioned in the cupboard on the left-hand side of the unit as you walk in. They should be on the baby's incubator for the first week of their life. I've seen them left on for a bit longer than that, but I feel like they might lose their power as a reminder if they're left on for too long. So please try to take them off if you see them on longer than that. Babies who are receiving the neuroprotection care bundle are being highlighted at the morning safety briefing. We are using teaching sessions, of which this is one, and the nursing staff and the medical staff are receiving training. We are working on integrating the checklist into Epic, but for the moment it is still on paper. To finish up, I want to talk about some things which aren't part of our routine practice and aren't part of the neuroprotection care bundle, but nevertheless may be associated with a lower risk of intraventricular hemorrhage. Some of this is my opinion rather than standard unit practice, but it's all something to consider. The first item on the list is prophylactic indomethacin. Now, this is largely an academic point because prophylactic indomethacin simply isn't available in Europe. Having said that, some older randomized controlled trials did show that prophylactic indomethacin was associated with a lower rate of IVH. That's probably because it results in earlier closure of the duct, and so there's less steal by the pulmonary circulation of the outflow from the left side of the heart. Interestingly, the same has not been found to be true of ibuprofen, a very, very similar medication. I understand that some trials of that are planned, however. The next thing is respiratory issues. Now, I already mentioned some of them, and I want to reiterate that we should be aiming to avoid intubation wherever possible. And I mentioned that when a baby at risk of IVH is being intubated, that is not an appropriate time for somebody to be trialing intubation for the first time. What I want to plug here is video laryngoscopy. There is some recent evidence that video laryngoscopy in neonates in emergency intubations is associated with fewer attempts needed to secure an endotracheal tube, and we know that high numbers of intubation attempts are associated with the risk of IVH. The other thing that I believe is often a good idea is transcutaneous CO2 monitoring. I mentioned that we want to avoid extremes of CO2, and in a baby who is very unstable, transcutaneous monitoring may help us do that. Now, in babies with very fragile skin, it's important that we are vigilant to make sure they don't get skin burns. The transcutaneous CO2 monitor to work has to heat up, so it can cause burns, but the temperature is somewhat adjustable on it. And we haven't seen any burns here with our newer monitors, and the nurses are very vigilant to make sure that the site of the probe is changed periodically. The last thing I want to mention on this slide is sodium bicarbonate. Now, sodium bicarbonate is a controversial topic within neonatology. The rationale for its use in metabolic acidosis is that it may improve cardiac output, and it may also help to relax the pulmonary vasculature when there is persistent fetal circulation. However, observational data suggests that increased rates of use of sodium bicarbonate are associated with more intraventricular hemorrhage. Now, of course, that may be partly due to babies who are sicker being more likely to receive sodium bicarbonate. Nevertheless, there simply isn't enough evidence to conclude either way whether sodium bicarbonate is beneficial. What I think all of the consultants in Belfast would agree with is that the first efforts when you are confronted with metabolic acidosis should be to correct the underlying cause. So that may be that you need some careful fluid resuscitation. It may be that you need to start some inotropes. So thank you for listening to this talk. I really believe that if we implement this bundle well, we will see less severe IVH in the unit. The nursing staff have been so enthusiastic and diligent in implementing the bundle, and I just really want to see that matched by the medical team. It's hard for me to ensure that everyone has had some education about the bundle. So in order to do that, I have created a neuroprotection bundle quiz that I am going to ask that everyone completes. You can see a QR code there, and I'm also going to email around the link to it. Please, when you're doing it, enter your name into the first question box. I don't care what score you get. You can go back and forth and correct your answers. I'm not going to be tracking that at all, but I would like to see that everyone completes the quiz. Again, thanks for your time. I really appreciate it. If you have any questions or any suggestions, as I said earlier on, I'm really happy to hear them and to talk to you about it. Bye.